Hello, my name is Eamon Ferguson and I'm Professor of Health Psychology at the University of Nottingham. I'd like to thank Barbara, Mel and Courtney for the kind invite to talk today as part of the symposium on the diversity of donor panels. I'm going to talk primarily about a project called For the Assessment of Individual Risk, known by the acronym FAIR. I'm going to talk primarily about FAIR 1, which looks at diversity with respect to men who have sex with men, and spend a little bit of time talking about FAIR 2, which looks at diversity with respect to ethnicity. This is a large, multidisciplinary and collaborative project, and we've collaborated very closely with Dr. Sue Brailsford, Claire Reynolds and Katie Davison at NHSBT. And we've done the work that's primarily contributed to the behavioural component of this project, and we've been helped in that aspect with collaborations with Professor Ronan O'Carroll at the University of Stirling, Professor Jane Noyes and Dr. Leah McLaughlin at the University of Bangor. This slide provides a brief overview of the historical path to where we are today with respect to men who have sex with men and blood donation. Looking back to the late 1990s, 1999, men who had sex with men could be deferred either permanently or up to 12 months. We're now at a stage where in England and the UK, where we can assess everybody on their sexual behaviour. And this has gone through a number of changes. So back in around 2016, 2017 within the UK, men who had sex with men were deferred for 3 months unless they'd abstained from sexual behaviour. So just to recap that, previously men who had sex with men were unable to donate blood unless they'd abstained from sex for 3 months, and those recommendations were made in the UK and accepted. However, this was still seen as potentially inequitable and unfair, and calls were made to move towards more individualised risk assessment where everybody was assessed on their sexual behaviour who wished to donate blood. So this led to the call for the setup of the FAIR project. So men who had sex with men were deferred for 3 months, and this was considered inequitable and unfair. So the UK government asked NHSBT if they could set up a steering group and a project to identify ways to select donors based on their sexual behaviour. This project was headed up by Dr. Sue Brailsford and her team, who provided the epidemiological evidence primarily, and we were asked if we would provide the evidence to support a behavioural science component, and we were funded in that aspect by the UK Forum, which is the group of the 4 UK blood services based in England, Scotland, Northern Ireland and Wales. The unique thing about the FAIR project was this combination of epidemiological, behavioural and psychosocial social sciences coming together to be triangulated to reach a final conclusion about a set of behaviours or questions that could be used to identify people with high-risk behaviours to be screened from the donor pool. Focusing now closely on what the work plan of the FAIR project entailed. So it was set up in February 2019, a steering group was instigated with a final report to be delivered in October 2020, and we delivered that report on time, even though some of the work had to be changed slightly because of the pandemic. There were 3 strands: the epidemiological work, which was delivered primarily by Sue and her team at NHSBT, along with some of the behavioural work, and we provided the work primarily on behaviour and the psychosocial work. And that was delivered through a number of surveys, through focus groups, and all through looking at test reliability of particular questions. So we were interested in, would a policy change lead to people to perceive risk in a different way associated with blood donation? How accurately can people report on their sexual behaviour? Are there ways in which we can improve that accuracy, and what sorts of behaviours will people find it acceptable to report on? So not only do we want to find from the epidemiological evidence behaviours that were high risk and we needed to consider, but we wanted to find behaviours that people could recall accurately, that people found acceptable, and if there were issues around acceptability or accuracy, what could we do to actually improve that? So we did a number of surveys and focus groups to address this. So the first survey, which was done in collaboration with the University of Stirling and the University of Bangor, was a general population survey. We tried to get as diverse a population as we could, and the basic survey descriptives are given on this slide. The second survey was a survey of UK blood donors in Scotland, Wales and Northern Ireland. And again, we aim to get as wide a diversity as we possibly could with respect to sexuality and donor experience. And the basic demographics of this sample are given on this slide. So the first thing we're interested in was perceived risk. So to what extent would the new policy, or a policy that was based on sexual behaviour of everybody, rather than taking a population base and deferring a particular group, will this affect how people perceive the risk or the safety of the blood supply? So in both those surveys, we asked this same question. If the UK policy was to change, to what extent do they think this would lead to an infection risk in patients from down here, no risk at all, through to an extremely high risk? And as you can see from both surveys 1 and survey 2, in both England, Scotland and Wales, the risk was at around about 2, which is a small risk. So both in non-donors and donors and across the UK, people were perceiving that type of policy that focused on sexual behaviour to be one that would introduce or be a small risk. However, we're interested in comparison between the policies. So in survey 1, we asked people the extent to which to consider the perceived risk with respect to the current policy, where we have population-based screening, and the proposed policy where we have screening based on individual sexual behaviour. And here the scale ran from 0, no risk at all, to 100, a complete risk. And as we can see here, the risk is low for both the current policy and the proposed policy, but it is significantly lower for the current policy. So screening everybody on sexual behaviour moved people towards perceiving that policy as actually being lower risk than the current policy. But it must be stated, both the current policy and the proposed policy are right down at the low to no risk end of that scale. So what would be the effect on behaviour? So would a change in policy encourage people or discourage people from donating blood? Would we lose any donors? So again, in survey 1, when we asked about the proposed and the current policy, we also asked people the extent to which they would encourage other people to donate blood. And as you can see here, both for the current and the proposed policy, people would encourage, but much more so for the proposed policy. And that effect was seen in both straight and people from the LGBTQ plus community, but it was stronger in people from the LGBTQ plus community. So we have some evidence here that a change in policy, possibly because people perceive it as being fair and more equitable, would lead people put people in a position where they feel they would be much more likely to want to encourage other people to donate blood. So we know overall, in terms of the policy, therefore, that people think it would be one that would encourage people to donate blood. So now we needed to identify the sorts of sexual behaviours that we could look at, that we could actually use to screen donors on. So we asked people in the first survey the extent to which they had undertaken a variety of different sexual behaviours. And we used factor analysis to identify clusters of behaviours. And we see 3 clusters of behaviours emerge. One, which was high epidemiological risk. So this is people who have had a new sexual partner, more than one sexual partner, have undertaken to use chemsex, and have a recent diagnosis of a sexually transmitted infection. So people who have a new partner are more likely to also have had more partners, to have used chemsex and been diagnosed recently with an STI. So this we've seen as identifying the epidemiological high-risk behaviours. And from our perspective, very importantly, the epidemiological evidence that was reviewed also showed that those behaviours were the behaviours that were associated with higher risk of infection. So we had both the epidemiological data and our behavioural data converging here. There was then also a factor that related to penetrative and receptive sex, and one that related to safe sexual behaviours. Okay, we see that the epidemiological high risk sexual behaviours were associated negatively with impression management. So what this means is people who wanted to create a positive image of themselves are less likely to report those behaviours. And with this knowledge, we can start to think about how we normalise or start to talk about sexual behaviour in the donor context, so as people don't feel as though they have to impression manage. So again, we have some additional behavioural data that helps us inform how a policy might be implemented on the ground. We also ask people to rate their own risk of an infection, this absolute risk of infection, from their sexual behaviour. And we also ask them to estimate their optimistic bias of an infection. Here, people could say that they were less likely than the average person to get a sexually transmitted infection, about the same as the average person in the UK, or at greater risk. And what we see from here, people who scored higher on the epidemiological high risk behaviours also reported they were at higher risk of getting a sexually transmitted infection and had less optimistic bias. They rated their chances higher than the average person in the UK, whereas those who reported having safe sex reported their risk of their reported optimistic bias. Essentially, they were less likely to get a sexually transmitted disease than the average person in the population. So we have some evidence here that the sexual behaviours we identify have resonance with and correlate with people's perceived risk, which is important if we want people to self-defer or think about their own behaviours with respect to risk. And it also means if we talk to people about their behaviours with respect to risk in a donor context, then we know that people who are likely to be engaging in high-risk behaviours are also seeing themselves at high risk. When we asked about the sorts of questions, whether people find them appropriate or inappropriate to answer, so this scale here is on inappropriate, we see that anal sex and number of sexual partners were the ones that were rated probably the most inappropriate from our surveys. We also conducted another survey as part of a larger project with as part of the BEST group, and again, anal sex is seen in there as one of the questions that people might not be comfortable with being asked about. We also asked if the questions would put people off donating blood, and again, anal sex is the one that emerges as a question that people feel is more likely to put them off donating blood if it was asked. But again, knowing about this, if anal sex is a question we end up asking about, we know it's likely to cause concern. We can try and frame the way it's discussed or introduced to minimise any distress. We also asked people if they think that what questions they thought would put other people off as well as themselves, and we can see there's a high degree of congruency. In fact, they were highly correlated, around about 0.8. What people perceive will be the questions that would make them think about self-deferring or not donating are very, very similar to the questions they think will put other people off. So there's a normative sense here in which certain questions are seen both by the individual and likely to be seen by other people as a potential deterrent. And again, knowing this means we can think about how we frame or discuss those questions in any policy change or in any donor context. So that's a brief summary of some of the data we got from the surveys. I'm going to talk a little bit about now some of the data we got from the focus groups and interviews. So we did a number of focus groups with men who have sex with men and a number of interviews, and we did a number of interviews with donor staff and with patients. We were planning to do all these as focus groups, but we ended up having to move to online interviews due to restrictions due to COVID and the pandemic. So what do these focus groups and interviews sort of reveal? So if we start with the patient interviews, a number of interesting ideas and concepts emerged from the patient interviews. So the current system was seen as unfair, and there was a feeling that a change here would lead to equity and would be a good thing. There was issues about cost benefits analysis, how many MSM will become donors, how many current donors will be lost. So again, the patients here who are from the UK Thalassemia Society were expressing because might we lose some donors. And this is partly because for these patients who are continual users of blood, they are so grateful to what blood donors do in terms of their benevolence, their caring, their altruism to help by donating blood. And I was struck by the patients talked about donors not just as saving lives, but saving life. That through blood donation, people who required repeat transfusions, such as people from the UK Thalassemia Society, this meant they had a life, not just saving their life in the sense of, people often talk about blood saves lives. This was their life. They were so grateful to the blood donors, and one of their main concerns was they didn't want blood donors to be put off donating blood. But they also raised issues about intersectionality, being sensitive about asking these questions in terms of asking them of different ethnic groups, and matching the donor and the carer together in the donor selection process. So again, they were aware of the sensitivities of the questions and came up with some interesting ideas about how we could potentially manage that on site. Again, questions that might be uncomfortable. The number of partners, oral sex and anal sex, were again mentioned, and that corresponds very closely with obviously the results that came from the survey. They were concerned about memory and accuracy, so the extent to which people may not be able to remember or may actively not report their sexual behaviour. And again, this is an issue that we can think about in terms of what sorts of techniques can we think about that may enhance accuracy of reporting within the donor selection context. They talked about campaigns to encourage and reward donors and acknowledge what they'd done. And another important, I think, concept that came out of the patient interviews was the idea of talking about blood donation and not talking about donor health checks, but talking about donation in terms of thinking about it in terms of safety, and it being about a donation safety check, and thinking about it in terms of having the donors really think about the recipients, who they're donating the blood for. So trying to make that concrete psychological link and behavioural link between the donor and the recipient. In terms of staff, here are some of the sort of a diagram that highlights some of the issues that came out when talking about specific questions. I'm not going to go through this diagram in detail, but what I want to highlight is primarily the things that were coming out, the things again about accuracy, again, with all the questions, which may be due to people forgetting, or it may be through actively being dishonest. So again, there's accuracy of recall. There's issues about the relevance and intrusiveness of questions. And again, so how could we make that so that people understood why we're asking the questions and didn't find them intrusive? And how, again, can we enhance memory and accuracy? And again, for all the questions, memory and accuracy comes up, as you can see. And again, similarly, when we ask donors about the specific questions, again, issues about accuracy, issues about emotional responses. People might be embarrassed and therefore may not report their behaviour. So again, it gives us some ideas of things we can look towards in terms of how we can manage the situation to make behaviours feel more normative, so people are less embarrassed by them. We can maybe even ask people to use their mobile phone so they can look back as an aid memoir that may help in terms of forgetting. We can normalise and give information so people understand why we're asking the questions, which deals with issues about intrusiveness. So again, by asking about the specific questions, it gives us ideas about how we can go forward in terms of implementing any policy. In terms of support for change, it was seen by all people we spoke to as a positive move to increasing equality and fairness and updating the current practices. There were some concerns obviously raised, again, about intrusiveness, any negative emotional reactions or other reactions, and people's dishonesty. But overall, even when we were asking about the policy, people were talking about it in terms of the benefits really outweighing these potential concerns over here, and what we can do is we can find ways to deal with those concerns so as we get maximise benefits. And again, when we looked at concerns in particular, again, there are issues about donors' questions about why the policy. So again, we can address that. Issues about logistics, how long it's going to take. It's going to increase the length of any appointment, so on. And again, that's stuff that can be thought about in terms of training and management on site. And again, people talk about using it as talking about the donor screening in terms of a safety check rather than as a health check. Because now we're talking about behaviours as much as health. We're looking at screening for safety. Okay, so it might be worth thinking about renaming the donor health check as something like the donation safety check. So overall, all the evidence from the behavioural science side triangulated almost perfectly with the data from the epidemiological side in terms of the questions that we should ask, and the behavioural evidence inform that a little bit as well in terms of what the issues might be, how we might manage those in terms of acceptability, in terms of memory. And we ended up with the following sort of set of questions or recommendations to how we would, questions that we would ask that could be implemented. So the questions are, have you been treated for syphilis or gonorrhea in the last 12 months? If yes, then there'll be further questioning, and you can see what that is at the bottom. If no, continue. Have you had sex, taken recreational drugs excluding Viagra and cannabis in the last 3 months? If yes, defer. If no, continue. Have you had more than one sexual partner or new sexual partner in the last 3 months? If yes, ask questions below, which is a gateway question. So if no, they can donate, but if yes, they then ask a question about anal sex. And if the answer is yes, they are deferred, and if no, they can donate. And as you may recall, the question about anal sex was the one that people saw as the most inappropriate and the one most likely to deter. But as you see, this is now only asked of people that get to the gatekeeper question here about the number of sexual partners or new sexual partners. So it's not going to be asked of everybody, and only a small group are going to see that question. And again, because it's embedded within a broader set of questions about sexual behaviour and people know about the policy change, we are hoping that that sort of helps people normalise that behaviour and helps people feel it's more acceptable because they know the question is coming up if they're going to be asked. So as part of the programme of work, we need to be looking at post-implementation. So post-implementation is the epidemiological team are looking obviously at the viral, are there any evidence of increased infections, but we're going to I'm going to talk primarily about the behavioural analysis that we've done post-implementation of the FAIR project. So we've been looking at behaviour. So we've done 3 studies post-implementation. So I'm talking about post-implementation. So obviously the recommendations that were made were taken on board, given ministerial approval, and the changes have been made such that blood donation is now on a selection in the UK is selected on sexual behaviour rather than population based. So we've done 3 studies post-implementation. The first study is looking at in all 24 centres in the UK from October to December in 2021. We had a QR code in the donor centres, and we just asked people to click on the QR code to a short survey, and that survey was basically just recording demography of who was attending. And we're interested to see if there was an increase in number of men who have sex with men, and yes, there was. The percentage of people self-identifying as MSM had gone up from around about 1.5% to just under 3.5%. So we've seen a positive increase in the number of MSM donating over time. We also conducted a number of interviews with staff, and these were to identify any issues or concerns or any positive outcomes of the change in policy. And overall, it was seen as a very and welcomed as a very positive change. Interactions with donors, in particular with MSM donors, had improved and were very positive. Staff felt well prepared. They felt as though the policy was fairer and less discriminating, and just led to a much more positive vibe within the donor centres. And one issue that did come up is around polyamorous people who feel there may be alienation, they may have been alienated, or there may be problems with some of the FAIR rules. And of course, this is something that we will now look into, that it has been raised. We also did a survey with the general public where we oversampled men who have sex with men so we could get their views, and we also sampled patients through the UK Thalassemia and Sickle Cell Disease Societies. So I'm going to look at this in a little bit more detail on the next slide. So what we see, so we asked people in this survey, people filled in some questions about perceived risk. Then they were given within the survey a detailed or description of the policy change, and then they were asked to make a set of subsequent ratings based on their now understanding of the policy. So these, after they'd read about the policy, they were asked to rate their emotional reactions from awful through to fantastic. Okay, and what we've got here is their ratings by in pink, the patient groups, in black by the general population, excluding men who have sex with men and the patients, and in blue, men who have sex with men. As you can see down here, overall, it was positive, patients saying okay, and slightly higher, really good for the MSM, and the population excluding patients and MSM. However, it was the emotional positivity was slightly lower for the patient group. In terms of risk, here we have got the pink is a patient group. As you can see here, in terms of perceived risk, the patient group, which is here, this graph, moves from below the midpoint, not a great risk, towards the higher point of it being a risk, and that is significantly different. So when the patient group have been informed about the policy change, their perception of risk is increased. It's still low, it's still in the acceptable to low region, but it increases. Whereas for MSM and the general population, excluding patients and MSM, there is some move, but it's generally down towards the lower end. When we asked about acceptability of risk, both MSM and the general population, excluding MSM and the patient group, see the risk as acceptable, and it doesn't really change post knowing about the policy or getting some additional information about the policy, whereas the patient group see the risk as less acceptable. So we wanted to take some qualitative evidence to find out why the patient group in particular were rating the emotions slightly lower, and that being then translated into possibly potential feeling that the risk is slightly higher compared to the other groups. But I must emphasize here, risk here is not being rated as completely unacceptable, and risk is extremely high. They're just higher relative to the other groups. So for each, we asked everybody, and here I'm just focusing on the patient group for the moment. Once they made their emotional response, they'd circle one of those emojis just to give a free response as to why they'd made the response they'd made. And what we see here is from the patient groups, those who said they thought the change was awful, they see this as a greater risk of infection slipping through. And again, they linking this to people not being accurate or telling the truth about their sexual behaviour. People who saw it as not very good. Again, there was concerns about the risk, and again, issues about memory and honesty. So again, this highlights that we really need to focus in on thinking about how we ensure that people are being accurate in their reporting of their sexual behaviour, and how they feel supported, that they can be honest about that within a social context. People who say it was okay see it as a good thing, that people should feel to choose who their partners are. When we get to really good and fantastic, this is a move to equity also. It brings forth new donors. Again, it goes back to the work we've done with patients pre-implementation, where they're concerned that there might be a reduction in donors. So those who see this as a really positive move are also seeing it as a positive move, so seeing it as a way of bringing new donors into the donor pool. And fantastic, blood is blood regardless of sexual orientation. Blood will save lives. So again, what we're seeing here is people who are the concerns are really about memory and accuracy of recall and people telling the truth. And the positives are really about it's going to increase the number of people able to give blood, and it's a good and fair thing. So we need to think about how we ensure that those concerns are addressed. So given the success of the FAIR project, FAIR 1, FAIR 2 was instigated, and this was with respect to diversity of the donor pool with respect to ethnicity. So on the donor health check, as it used to be at the time, there was a question that asked about in the last 3 months since you last donated blood, have you had sex with anyone who may ever have had sex in parts of the world where AIDS, HIV is very common? This includes most countries in Africa. Now, this was seen as potentially discriminatory against people from Black and African communities and backgrounds. So we did some behavioural work where we asked people, presented people with that question and asked them the extent to which it may put them off donating blood themselves and people from their community, or the extent to which they would tell people from their community not to donate blood. And we found that in Black communities, this question led to a high proportion of people saying they wouldn't donate blood, and they would tell people from their community not to donate blood. Again, the epidemiological evidence was reviewed, and it was felt that there was no substantial gain by having this question on the donor health check. And again, bringing the behavioural and epidemiological evidence together, this question has now been removed from the donor health check or the donor safety check as it is now. So hopefully this brief presentation has shown how bringing together behavioural, epidemiological and social science data together allows us to inform behaviour change in the area of blood donation, allows us to think about what policy issues might need to be considered and adopted as that implementation goes forward, and provides a strong basis for supporting any change. Okay, and in this final slide, I just want to acknowledge this has been a big team effort. Even though I've presented the work that we've primarily done on the behavioural sciences, there's an enormous amount of epidemiological work that's been conducted and undertaken by Sue and her team, as well as some behavioural work by Sue and her team as well. There was a steering group, so all the work that we did as part of both FAIR 1 and FAIR 2 was brought back and presented to the steering group, and the membership of the steering group for FAIR 1 is detailed here. The steering group helped us develop further studies, helped us interpret and understand the data that we were getting and how that could be translated and implemented into policy change. So there were checks and balances by all groups all the way through the whole process, and it was a developmental process to end up at the most optimal solution to the problem. How do we change donor selection to be on sexual behaviour, and one that leads to a fair and safe outcome? And I think as a case study, I think FAIR 1 and FAIR 2 are really nice examples of how behavioural and epidemiological sciences can come together to deliver a strong case for policy change. If anybody's got any questions, I think they can be posted through onto Barbara, Mel or Courtney, or onto me. You've got my email there, and I've also put a few links in here to the reports for the FAIR 1 and FAIR 2 projects that you can see online, so you can get to read the whole reports in detail, not just the summary that I've given today. So I'd like to thank you for listening to me, and if you have any questions, please do forward them. Thank you very much.